All right. So again, thank you for making the time to turn up to, it's our last Nurse Talk of 2025. And I think it's going to be another great one. We have two very amazing talkers this morning. So we've got Kate she's an educator at the National Critical Care and Trauma Response Centre. She's obviously sat next to me here in Darwin. And also we have got the infamous Sister Dulcie, who will also be joining Kate in this presentation on electrolyte imbalances and ECGs. So thank you both for volunteering your time to join us today. And I am going to hand over to Kate. Thank you.
Hello, everyone. Thanks for having me. I've been really looking forward to this and getting involved. Yes, thank you. As Beth said, I'm one of the educators at the Trauma Centre, and I might let Dulcie, I'm sure you all know her by the sounds of it, but we might start off with Dulcie just introducing herself, and then if it's okay, it would be great if I could get everyone to tell me their name, where they're from, and what their job is. So, Dulcie, do you mind if we start with you and then we can move around to everyone?
Yeah. Thank you, Kate. Thank you, everyone, for joining us on this morning's Zoom again. My name is Dulcie. I'm a critical care nurse in Alota Hospital, which is in Papua New Guinea, and it's located right on the far eastern tip of the main New Guinea Island. I've worked as a critical care nurse, general nurse, for about 5 years before undergoing studies. So this will be the 5th year of specialty in the ICU. And my passion is centered around teaching, and I'm glad I have this opportunity with NurseTOK. So thank you, Kate and Beth, for this collaboration. Thank you.
Thanks, Dulcie. Hilda, do you mind if we start with you? Just your name, where you're from, and your position.
Thank you, Beth and Kate. I'm Hilda from Pomclen, ICU. I'm a nurse in ICU, and I have 1, 2, 3, 4, 5, 6, 7 ICU nurses sitting in my office.
Oh, that's amazing. Great. Thank you so much all for coming and for your time. I'm sure you're really busy.
7 of them.
7 of you. Great. I'll try not to fumble my words too much then. Just so I don't get lost, on my screen next we've got Rhoda. Do you mind unmuting your microphone? Oh, can't hear you, Rhoda.
Oh, yeah. Is it me? Okay. My name is Sharon Sunafua. I am currently working in Samoa as the focal point for Samoa Emergency Medical Assistant Team. My background is a registered nurse and a midwife.
Amazing.
Hmm.
Thank you. Thanks for coming along, Sharon. Who is next? Oh, Rhoda, we've got you unmuted now. Where are you dialing in from this morning?
I'm dialing in from Goroka Provincial Hospital. I'm a emergency specialist nurse.
Amazing. Great. Thank you for coming. Have I done Belinda yet?
No.
Belinda? There she is. Hello. Where are you dialing in from, Belinda?
Hello, good morning. I'm ICU specialist nurse currently working at Rabaul Provincial Hospital, East New Britain Province.
Thank you. Thanks for taking the time to come. We might go to Matilda.
Hi.
Hello.
Hi, I'm Matilda. Hi, I'm Matilda. I work here in Samoa in the ICU.
Thanks for coming along. I think we're up to, is it Addie?
Bula, I'm Andy Aluesi. I'm currently the nurse unit manager for Women's Medical Ward in CWM Hospital here in Fiji, but still heavily involved in ICU. I was in ICU for 5 years before I took up this post. Yeah.
Great. Oh, thanks for joining us. Maria.
Hello everyone, Maria, I'm in Aspen Medical Lotoka, currently in ICU.
Great. Thank you for coming. Garuna? Someone on the chat. Thank you.
Oh, okay. Thanks, Garuna.
Thank you. Garuna, clinical nurse educator, research. Is that
researcher on the medical ward at PomGen Hospital.
Great. Thank you so much for joining us. So we've got two computers going, so I'm looking at a couple of screens. Lucia?
Hello, everyone. I'm Lucia. I'm a registered nurse at the ICU based at CWM in Suva, Fiji.
Amazing. Thank you for joining us. And Naomi?
Hi, good day.
Hello. Where are you dialing in from?
Hello. From PNG, Medang. Currently, I'm on my break, and I'm a medical officer. I heard you're all nurses, but I'm a medical officer. I saw this, so I was interested to join. So, yeah, I dialed in.
Great. Thanks so much for coming. I think that I've covered everyone, but just seeing out if I haven't. The screen's been moving around a bit. Did I miss anyone? Yeah. Great. Well, again, thank you so much for coming and taking the time out of your busy days to come along. I should also say, I guess, what my position was. So, when I worked clinically, I work as an emergency and an intensive care nurse. So it's great that we have so many people from different areas joining. And when I do get a bit nervous, I can talk quickly. So if I'm speaking too fast, please just pop it in the chat, or if you just unmute and tell me to slow down, that's absolutely fine. And hopefully everyone can see my screen okay. One moment. There we go. And then if I, oh, maybe I'll do it this way. There we go. Can everyone see the screen okay? Welcome, Hannah.
Yes, you can.
Okay, perfect. All right. Hannah, can I just quickly ask where you're dialing in from? And your microphone's just muted, sorry. That's all right. We're having some microphone issues, so we might ask you in the chat if that's okay. Okay, so Dulcie and I are going to do a presentation on electrolyte disturbances and its potential effects on electrocardiograms. So I will start off, and the intended learning outcomes for this session. Sorry.
Slow down a bit.
Okay. So the first thing that we're doing is just a bit of a revision on the components of ECG. So this is reflecting on Beth's presentation that she did with you last time. So we're just going to start off by looking through that. We're then going to look at potassium, so high and low potassium. We'll explore what that means and what ECG changes you might see with these conditions and how we will treat it. We'll then do the same thing with magnesium, so looking at high and low magnesium and what potential changes you will see on ECGs that correlate with these conditions. We will then look at the treatment for those as well. And then what you all came for, Dulcie, she will present the same thing, but we're going to be looking at calcium. So looking at high and low calcium and what changes to the ECGs can occur because of these conditions. She'll then explore with you how we will treat that. So firstly, a bit of a revision on ECGs and what Beth went through with you a couple of sessions ago, I believe. So the heart has a mechanical and electrical component. The coordination of normal cardiac function relies on electrical activity in order to generate cardiac output. We have two atria, which is at the top of the heart, and two ventricles down the bottom. We know that the electrical activity starts in the atria and then travels down to the ventricles. When we have disturbances in the normal electrical pathways of the heart, it can sometimes impact the performance of the heart, so how well it pumps blood around the body. When these alterations are severe or they go on for a long period of time, the patient can become very sick and organs begin to fail. So in normal health, we know that the electricity starts in the atria, so the SA node, which you can see on the bottom picture of the heart there. So starting at the SA node, it then spreads across both sections, both areas of the atria, and then goes down to the AV node. From there, it travels down the ventricles into the bundle of His and makes the heart contract. So I'm going to show a little video on how that works. So hopefully this all works. So you can see there, the electricity starting up the top of that atria, traveling across and down to the the SA node, down the bundle of His, and down into the Purkinje fibers, making that heart contract. Okay, so what this means and how it relates to the ECG, which we'll go through throughout the whole presentation. So starting off with the P wave, so the first component of the ECG. So the P wave represents the atrial activity. So initially starting in that SA node and then spreading across both atrias. So we call that atrial depolarization, so that squeezing of the atrias. The PR interval, which is in the light pink, that flat section, that is representing when the electricity travels from the SA node down to the AV node. Then we're looking at the QRS complex. So that big spike is representing the electricity traveling down the ventricles and squeezing to eject blood out to the rest of the heart, to the rest of the body, sorry. The ST segment, so that other light pink flat section, that is when the ventricles are in that squeezing phase, ejecting the blood out to the rest of the body. Finally, the T waves, so the last component of the ECG, that's looking at when the ventricles repolarize, meaning relax. So the ventricles relax and the heart can then fill with blood again. So again, a little video to help reiterate that.
This animation shows how the different ECG waves are produced during a cardiac cycle. The P wave is produced as the electrical impulse travels through the atria, causing them to contract. The P wave corresponds to atrial depolarization. The impulse then travels through the atrioventricular node, producing a flat section on the ECG, known as the PR segment. The PR segment is flat, because no current is flowing through the cardiac muscle cells. As the impulse travels from the AV node to the bundle of His and along the upper part of the septum, the Q wave is produced. The passage of the electrical signal through the ventricles produces a large spike called the QRS complex. The QRS complex is much larger than the P wave because the ventricles are much larger than the atria and so produce more electrical activity. Most of the QRS complex represents depolarization of the left ventricle, which has much greater mass than the right. The impulse remains unchanged for a moment as the ventricles remain depolarized. This gives rise to another flat section called the ST segment. As the impulse fades away and the ventricles repolarize, the T wave is formed. Note, this animation shows the ECG recorded from a lead placed at position V6, one of the standard electrode positions to the left of the heart. Leads at other positions detect the electrical activity of the heart from a different point of view, and therefore produce differently shaped ECGs.
So this is just putting it all together. It's a bit of a busy slide, so apologies for that. But you can see what the ECG and the components look like on the left side of the slide. So that's just putting everything together we've just spoken about. On the right side, it shows you kind of what it looks like on a printed ECG. So with our little squares, help us record time. So we know that the heart beats many times a minute. So all of these different phases of the ECG happen in a fraction of a second. So when we're looking for ECG changes, we look at how long each component takes, and we use the little squares on the ECG to measure that. So you can see one small square is only 0.04 of a second, and then one big square, which is 5 by 5 little squares, is looking at 0.2 seconds. So you can see all the normal ranges down the bottom on the right hand of the slide, and that tells us how long each segment should take, essentially. I won't go through them each individually. You can have a look on the screen, and when we're talking about changes, we'll talk about what normal is versus not normal. So that was a quick little revision on ECGs and the different components. So now we're going to look at potassium and its effect on ECGs. So we're going to start with hypokalemia, which means low potassium. So that is any serum potassium level less than 3.5 millimole. So our normal range sits between 3.5 and 4.5. And then there are varying degrees of low potassium. So you can see on the screen there that we have mild, moderate, and severe. So our mild is when our potassium sits between 3 to 3.4. Moderate is 2.5 to 2.9. And then severe is anything less than 2.4. So typically we don't actually see ECG changes until the patient is sitting in that moderate degree of low potassium. So now we'll have a quick look at what those ECG changes are. So the first thing that you're going to see is the flattened or inverted T wave. So you can see the picture on the left, we've got a little arrow pointing to the T wave. So it's inverted in this example. Rather than pointing up, it's pointing down. Following on that, you can see that there's a U wave. And the U wave might be something that's new to you or a bit unfamiliar, and it's quite specialized to low potassium levels. So potassium plays a key role in helping the cardiac cells repolarize, so that means to reset after each heartbeat. When the potassium levels are low, that resetting phase takes longer. This delay then appears on the ECG as an extra deflection, which is that U wave, which you can see on the left-hand side of the screen. So essentially, this is representing delayed ventricular repolarization. So that delayed resetting of the ventricles. Additionally, you can see as well that the ST segment, so remembering that's the little flat, it's meant to be a flat line between the S and the T wave, that then becomes depressed. And again, that's because of the additional time that the ventricles are taking to repolarize. The last thing that is a feature of low potassium with ECGs is that prolonged QT time. So because we don't just stop at the T wave, we've got this additional U wave because that whole repolarization of the ventricles is taking longer. We have a prolonged QT interval. So these abnormalities have the potential to develop into life-threatening arrhythmias such as torsades, ventricular fibrillation, and ventricular tachycardia. So just to help compare what a normal ECG looks like here, you can see the ST segment is nice and flat. We've got an upward-facing T wave and no additional waves. Whereas if we go back to this example, the ST is starting to face downward rather than being flat. Our T wave is completely inverted, and we've got that additional U wave there. So sometimes it can take quite a while to get a potassium level back, depending on what you have, what lab equipment that you have access to. So we want to build a picture of our patients and not just rely, you'll have to wait for a lab result to come back. So it's important that we know what the symptoms are of low potassium. So I've got them on the screen here. So muscle weakness, lethargy, fatigue, so coming in just feeling really exhausted, tired, maybe some confusion, and increased urine output. They're all signs of potential low potassium levels. It is tricky though, because people don't always have these symptoms. So it's important to know what some red flags are when patients present to us. If they're presenting with any of these conditions or this history, we can be suspicious that the potassium level is low. So if someone comes in with vomiting and diarrhea, or reduced intake, so whether they're fasting for any reason, if they've had poor nutritional intake, or they're just feeling nauseous and vomiting, so they haven't been eating and drinking as much, then they have the potential to have a low potassium. Either they're excreting lots of potassium with their urine or stool, or they're not taking enough in. Medications can also affect our potassium levels. So diuretics like furosemide, insulin, and other medications like salbutamol and adrenaline can all have an effect on our potassium levels. And another reason to be suspicious is if we have other electrolyte disturbances. And I'll go through that a little bit more when we move into our magnesium section of this presentation. So essentially, if you're seeing ECG changes or the patients have those symptoms, they're presented with these potential red flags, be suspicious that the potassium level is low. Of course, if you have access to the lab, that's going to confirm your suspicion. Otherwise, we can start going down the treatment pathway for someone with low potassium. So what that looks like. Treatment. So it's going to depend on the level of low potassium, but essentially we can replace potassium either orally or intravenously. So depending on what you have available to you, will alter what your decision is essentially. We'll go through a couple of options. So if we are replacing the potassium intravenously, often we'll use 10 millimole of potassium chloride. So they will come in a vial, which then you will add to 100 mils of normal saline. It's really important that we measure how quickly we're giving this potassium, because of course we don't want to overdo it and end up with high potassium levels, because that can also be quite life-threatening, which we'll cover in a moment. So it's important that we're giving this either through a volumetric pump or we're using our drip rate. So The goal is to give 10 millimole in 100 mils of normal saline over 1 hour. We want to monitor what the response is to this treatment. So having a look at the symptoms, whether that's the symptoms we went through clinically or if it's the symptoms of ECG changes, we want to see those things improving. So that's how we're going to monitor it. In the moderate to severe cases of low potassium, if you have access to cardiac monitoring, it would be great to keep them on cardiac monitoring so you can constantly assess how they're responding to the treatment. Of course, we want to treat the underlying cause as well. So thinking about those red flags we spoke about before, so that's thinking about the patient's history, whether it's their medical history or history just prior to presenting, we want to fix those things because we can replace the potassium, but if the patient is still has the vomiting and they still have the diarrhea, they're going to continue to lose that potassium. So it'll be a bit of a never-ending cycle. So the other options, we have our intravenous potassium we're going to give. We also have the option of oral replacement. So in my setting, we use Chlorvescent. Just become familiar with what you have in your setting for your oral replacement as well. But that, of course, is going to take longer. So more suitable for your mild low potassium or for that chronic low potassium where you're having to give it quite frequently. Just something to note as well, when we're giving potassium infusions, it can be quite painful at the insertion site of the cannula. If that does occur, you can slow down your infusion or further dilute it if they're not fluid restricted. But it's just really about replacing it and then monitoring for its effects and talking to your patient and making sure that there's no pain and discomfort. So as you can see on the screen, and as I mentioned before, we want to avoid rapidly infusing potassium because we don't want to go to the other end of the scale and give too much potassium because we can also cause fatal cardiac arrhythmias from giving too much. So that's leading us into the session on high potassium levels now. So it is defined as any potassium level over 5.2 millimole. It does become a bit challenging because the main ECG, the bigger ECG changes that we see don't occur until around the 6 millimole mark. But just like low potassium, there's varying degrees of hyperkalemia, which means high potassium. So our mild range is looking between that 5.3 to 6. Moderate is 6 to 6.9. And they define severe hyperkalemia as anything over 7 millimole. So we're going to look at the ECG changes that you might see with high potassium. So in the first thing you're going to see, so in the mild range, are these really classic and quite obvious most of the time, peaked T waves. So you can see here that these T waves are sitting higher than even our QRS complex. So they're really quite peaked, and it's starting to tell us that our ventricular repolarization, so the ventricles relaxing, filling with blood again, there's starting to be some abnormalities with that phase of our cardiac function. So you do see this in the mild range, and then you tend to continue to see this as the potassium increases and our ECG worsens. So as the potassium levels continue to rise, ECG changes can potentially become worse and the changes can accumulate. So you're still seeing that peaked T wave, but then we're starting to see some additional changes on top of that. So this is looking at the moderate range of high potassium, so looking at ranges 6 to 6.9 millimole. And you're starting to see the widening or the flattening of the P wave, so they're not sitting up quite as high, and that PR interval is beginning to become longer. So this is telling us we know that the P wave is representative of our atrial activity, in the heart. So there's beginning to be some issues with that as well. So as the potassium continues to increase, this phase of the ECG worsens, and that shows us that progressively our atria are becoming more paralyzed, so they're not working as well. So in this moderate range, you can see our atria are being affected and our ventricles are as well. So you can still see those peaked T waves telling us that that relaxation phase of the ventricles is taking longer. So as the potassium continues to rise, conduction disturbances begin or continue to appear. So we've got that widening and flattening of the P wave. So the picture up the top of the screen, you can see you virtually can barely see the P wave at all, which is telling us that that paralysis of the atrials is worsening. You can also see that the QRS complex, and this is what's an addition to the previous slides we've explored, but the QRS complex is starting to become wider, and they can sometimes have this bizarre appearance, but excuse me, you can see on the screen here that the QRS complex is widening. The heart will start to slow down. So this could look like it could remain regular, like sinus bradycardia, or you might see it slow down with atrial fibrillation. So the top and the bottom of the heart not really communicating very well together. And every phase of the ECG is taking longer. So the electricity passing from the atria down to the ventricles and then the heart relaxing again to fill with blood, everything's taking longer. So as the potassium continues to rise, the patient's risk of life-threatening arrhythmias continues to increase. As this increases more and more, the patient has the potential to go into those life-threatening arrhythmias, which include PA, which is the pulseless electrical activity, ventricular fibrillation, and potentially with that heart slowing down, going into asystole. So these are all rhythms that are associated with cardiac arrest. So if you're seeing these ECG changes, we really need to act quickly. Again, sometimes we don't have access to immediate lab results, so we should always be looking at our patient as a whole anyway and looking at the symptoms that they're presenting with. But symptoms that are associated with high potassium levels again include nausea and vomiting, fatigue, muscle weakness, so just generally feeling very lethargic. Their respiratory rate might drop. They could be having palpitations, which would make sense now that we know about the ECG changes, and a very late sign is paralysis. So some red flags. So if a patient is presenting with any of these issues on the screen, we can be suspicious that their potassium levels would be high. In my setting in the Northern Territory, renal disease is quite prevalent. We have lots of dialysis patients, and often they will come in with high potassium levels. So our kidneys are responsible for excreting excess potassium via our urine out. When we have renal disease, we lose that ability. So if someone comes in and they have a history of renal disease, we can be suspicious that their potassium level may be high. With trauma, rhabdo, and burns, these patients have severe tissue breakdown. So these damaged cells release intracellular potassium into the bloodstream, and it can cause a sudden increase in potassium levels. Further to this, medication can cause an increase in potassium levels. So these medications can include NSAIDs, non-steroidal anti-inflammatory medication, ACE inhibitors like ramipril, digoxin, beta blockers, chemotherapy, and of course, if we're giving potassium, that can also cause high potassium. If there's any questions, you can sing out at any time or pop them on the chat as well, and Beth will tap me on the shoulder. We can go through it. Okay, so that is the features of high potassium. So once we've detected that or we're suspicious of it, how are we going to treat it? So I think of high potassium treatment as a bit of a two-step process. So the first thing we want to do is stabilize the cardiac membrane. So the calcium it helps control the muscles that contract in the heart. And so we really want to optimize that muscle and the ability for the heart to do what it needs to do. So we're going to give calcium gluconate. So I believe that you all have calcium gluconate in your stock. So we're going to use 10% and we're going to give 10 mils of that. And that's something that can be given really quite quickly. So that's why we put that up there first, because it's something that can be done quickly and try to prevent worsening of any arrhythmias. That doesn't, however, lower the potassium level. So, of course, that's our goal. We want to lower the potassium. So we do this with salbutamol, 5 milligrams. So you can give that any way that you usually do, whether that's via a nebulizer, an inhaler, a spacer. We want to give 5 milligrams of salbutamol. Additionally, we can give an insulin dextrose infusion. So we're looking at giving 10 units of short-acting insulin, and we mix that with 50 mils of 50% dextrose. The reason for that is because we know insulin lowers our sugar level, so we want to prevent that. That's why we give it with the 50% glucose as well. So, of course, when we give this medication, it's really important to monitor the patient's blood sugar levels. So we recommend doing that for at least 4 hours after the infusion. So to recap that, the calcium is going to help stabilize the heart muscle, and the salbutamol and the insulin dextrose infusion is going to help shift the potassium back into the cells.
Can I sorry, Kate, can we interrupt? We've just had a segment from Lucia in Fiji at CWM. So they only use calcium chloride at CWM, as gluconate has been out of supply for many, many years. Just out of interest, what do you use in PNG? Is it chloride or gluconate? Gluconate. Or whatever is available at the time.
Hello. So in PNG, we have calcium gluconate that we normally use.
Right. Thanks, Naomi.
Should I confirm the dosing?
Yeah,
okay. Yeah, we will have a look at the end. I'll have to just confirm, make sure I have the right information, but we can also have a look at the calcium chloride dose, and we'll pop that into the chat as well. So either the calcium gluconate or the calcium chloride, they both have the same intention of stabilizing that cardiac membrane to prevent worsening of arrhythmias. So whatever you have available to you, you'll be administering that. Okay, so that's the first step of treating high potassium. So we've protected the cardiac membrane, we've pushed the potassium back into the cells, but that potassium is still in the body and we need to get it out of the body. So we can do this many ways, but we'll break it down into the 3 simple ways. So firstly, the kidneys, we can use diuretics, so give medication to help increase someone's urine output, and we can wee out that excess potassium. But of course, that's not going to be possible if the patient has renal impairment and their kidneys aren't functioning efficiently. The next thing is via the gastrointestinal tract. So I think most people have access to Resonium. So the way Resonium works is that it binds the potassium in the intestines and then excretes it out in the patient's stool. I know that in my practice, when I worked in ICU, we would quite frequently give Resonium. It can be given orally or it can be given rectally. So the doses vary a little bit. If we give it orally, we're going to give 15 grams, and rectally we're giving it 30. We're giving 30 grams. It is fast. It is quickly. It is faster absorbed when you give it rectally. So it takes, but it still takes about 6 to 12 hours. If we give Resonium orally, it takes about 24 hours to work. So this is why we're not giving it in severe cases of hyperkalemia and hoping that the potassium levels are reducing fast. This is something that takes quite a while. So just keep that in mind when you're thinking about your treatment preferences for treating high potassium. The other thing we can do, but I think in all of our settings, we know it's not that easy and that accessible, but we can use the dialysis machine to help filter the patient's blood and remove the potassium that way. There is a bit of a recap for potassium-related changes to ECG. This is a little snippet I took off Life in the Fast Lane. It's a really great resource. If you haven't already utilized it, I recommend going on and having a look. I use it all the time. So ECG changes that correlate with low potassium levels. You're seeing that downward facing T wave and the addition of the U wave. So thinking about someone pushing down the T wave and then it bouncing back up. Whereas when we're looking at high potassium, think of someone pulling that T wave up. So that's why we have that visual cue of the peaked T waves. Our P wave begins to flatten and our QRS complex becomes wider because the whole heart is starting to really slow down. That is potassium and its effects on ECG. We're going to move on to magnesium now. So I think before I mentioned some clinical presentations or clinical patient history that would make us suspicious of low potassium or high potassium would be other electrolyte disturbances. So low potassium and low magnesium, they often occur together. So magnesium is essential for regulating potassium balance. When magnesium is low, the body loses potassium more easily, and potassium replacement is hard to achieve, an increase in potassium. Magnesium is required for proper function of the sodium-potassium pump, which keeps the potassium. If magnesium is depleted, the pump becomes less effective. So that's when you're seeing the varying levels of potassium and sodium. So what all that means, if potassium is low, always consider the possibility of magnesium being low as well. You can't correct one without correcting the other. So if we're not correcting the magnesium and we're giving potassium, we're not going to see an increase in the potassium levels because we still have that impairment with our magnesium. So if you have detected that there is if the potassium is high or low, suspect that magnesium is also affected. So a normal range of magnesium is 0.8 to 1 millimole. So hypomagnesemia, which I'm just going to say low magnesium, is defined as any serum magnesium level under 0.8. Symptoms don't typically occur until about 0.5 millimole or less, of course. So what these ECG changes look like. The QT interval is going to start to become prolonged. And so that's again reflecting that ventricular contracting and relaxing phase of the ECG. So that starts to increase in time. Another sign is these ectopic beats. So you can see firstly the atrial ectopic beat in the middle of the screen. So what that means is that the atrial will fire off an electrical impulse early. So on the screen you can see normal beat, normal beat, normal beat, and then there's an atrial ectopic beat, and that's followed by the full ECG, so the full QRS complex, and then the T wave as well. But then there's a bit of a pause before our normal beats start again. So remembering that the atria is firing off an early electrical impulse, causing the heart to beat sooner than normal, followed by a brief pause before the next regular beat again. The other one, which I personally think is easier to identify, is the ventricular ectopic beat, which is down the bottom right hand of the screen. And it's quite characteristic. You see a broadened and sometimes bizarre looking QRS complex. So that's what you can see down the bottom. So these are all features of low potassium levels. Some other symptoms that the patient may be experiencing is muscle tremors, weakness, arrhythmias we've just been through, agitation and irritability, and confusion. So if you're seeing these things, just think maybe the magnesium might be off. The clinical scenarios or patient history that may be suggestive of this low magnesium, again, is poor intake, increased loss, medications such as your diuretics again, so your furosemide potentially, and of course other electrolyte disturbances. So what are we going to do? If we are suspicious that magnesium is low, we're going to give intravenous magnesium. So again, we're giving 10 millimole in 100 mils of normal saline, and you can give this over 30 to 60 minutes. Just important to be aware of the adverse reactions that may occur with this, and they include nausea, vomiting, and hot flushes. So if your patient does experience this and it's, they didn't already have the nausea and vomiting, it's a new symptom, all the hot flushes, we're going to pause the infusion and we're going to get the patient reviewed. We don't want to give the magnesium too quick. It can cause a bit of a rebound hypotension, so a drop in the patient's blood pressure. You might also see a drop in their heart rate and respiratory rate. And if those things do occur, again, we're going to stop the infusion and try to get the patient reviewed. If it's more of a chronic issue, we can give oral magnesium, and that might be something that we discharge our patients on. So we can give 120 milligrams, and this can be additional to our intravenous therapy. Moving on now to high magnesium. So this is defined as anything above the normal range of 0.8 to 1 millimole, so anything above 1 millimole. The ECG changes that we see that are associated with high magnesium levels are very similar to that of the ECG features associated with high potassium levels. So essentially, both the atria and the ventricles will become impacted by this. So we're going to see that flattening of the P wave, the PR interval becoming longer, the QRS complex becoming longer, and we've also got those peaked T waves, which were we went through with the high potassium changes. So now we know that that's affecting the atria and the ventricles, and it's also affecting the heart's ability to relax and fill with blood again, which is represented in the T wave. So often high magnesium can be described as asymptomatic. So the patient may not have any of these symptoms, but in a fraction of the cases they will. So muscle weakness, nausea and vomiting, low blood pressure, cardiac arrhythmias we've touched on, but something that's new and different from our potassium levels is our reflexes. I'm not sure if anyone has much experience in testing people's reflexes. So that's looking at the deep tendon reflexes in the patella, bicep, tricep, and Achilles tendon. As our magnesium levels increase, these reflexes become diminished. So in severe cases, they will be absent, but you will see a drop in the reflexes in these areas. It's not something that I frequently have done in my practice, so you would need to know what normal looks like with the reflexes. But it is something that we can look at for our high potassium, getting mixed up now, high magnesium levels. So keeping that in mind. So reduced reflex activity is also a symptom of high potassium. Sorry, magnesium. I'm nearly done. Dulcie will take over in a moment. So other red flags, if they have a magnesium overdose, of course, that is a red flag for high magnesium. Renal failure, and again, rhabdo. If the patient has a history of preeclampsia also, keep that in mind. We know that their magnesium levels may be high. The treatment, I'm not aware of any medication that helps shift the magnesium back into the cells. So the goal is again to protect that cardiac membrane. So like we discussed before, we're going to give calcium, whether that's calcium gluconate or calcium chloride, and that's to help stabilize that muscle and prevent any worsening of arrhythmias or ECG changes. And of course, if we're giving any magnesium infusions, we're going to seize those and get the patient reviewed. So that is potassium and magnesium in a nutshell. I'm going to pass over to Dulcie, who's going to go through calcium and the changes that may occur with high and low calcium. Dulcie.
Thank you, Kate.
Thank you.
Am I audible?
Yep, we can hear you. And if you let me know if you want me to change your slides, I'll be ready to go.
Thank you. You can proceed.
Oh, yeah. All right, there we go.
Okay, so thank you, Kate. Kate has covered a lot on potassium and magnesium imbalances that can be detected on an ECG. I'm learning a lot as well, and here's what we're going to just see in a nutshell for calcium imbalances. So hypocalcemia or low calcium levels is defined as a serum calcium level less than the normal range, and that would be 2.15 to 2.6. Now, the normal range for serum calcium is typically given for two different measurements. So we have the total serum calcium and ionized or free calcium. It's important to note the correction for albumin for those who have 24/7 lab services that are run. The total calcium value should often be corrected for albumin concentrations, since approximately 40% of total calcium is bound to albumin. So when there is low albumin, it can also cause the total calcium level to appear to be artificially low, even when the ionized calcium is normal. So that's just a note to bear in mind. And usually in PNG, it's the doctors who do a lot of these decisions and who interpret lab results. So the rather lab variation, another thing that we need to bear in mind is that we need to remember that normal value ranges may vary slightly among different laboratories. And this is due to the different testing equipment or chemical reagents that is being used and the population used to establish these reference intervals. But basically, calcium levels less than 2.15 to 2.6 would be considered normal, and what falls below this normal range is considered as low. So the mnemonic we use to give us a diagnosis or help us to diagnose low calcium would be PET score. So there is convulsions involved. We also have arrhythmias, and on the ECG, we'll get to see later on, there's going to be prolonged QT intervals. There is also tetany, spasms, and there are two signs that are prominent in calcium disturbances. We have the Trousseau sign and Chvostek sign that is indicative of low calcium. Also, there is paresthesia or numbness reported. So clinical history that may suggest hypocalcemia would include a recent thyroid or parathyroid surgery. Again, gastrointestinal issues, mostly seen in chronic kidney diseases or malabsorptions. Example would be a gastric bypass or pancreatitis. Sorry. There's also medications that can interfere with calcium absorption. And this is due to chronic use of maybe anticonvulsants or APIs. Drugs like omeprazole can reduce the amount of acid, and they're taken in to control the amount of acids in patients suffering from gastritis and hypersecretion of gastric acids. And when it does that, it suppresses the absorption or solubility of calcium, and so patients more likely to be low with calcium. Also, nutrition deficiencies, especially in vitamin D. Vitamin D is essential in the absorption of calcium, and so when there is a low intake of vitamin D, it also affects calcium and it may be low. Next slide, please. And so the ECG features that we can see on a patient with hypocalcemia would be a prolonged ST segment, thus the QT interval. So our QT interval begins from the start of the QRS complex to the end of the T wave. You can see on the screen, the arrow points right down at that segment. So calcium is seen as the signal giver. So at the end of the cycle, when the ventricles contract, it is calcium that keeps the squeeze, and it gives a plateau or a moment of a period of pause before moving on to relax. And so when there is low calcium, there is not enough of calcium outside the cells to rush back to give that signal, and so the interval becomes prolonged, and that's what we see on the ECGs. Next, please. Okay. Basically, in the PNG context, generally for acute to severe treatment of hypocalcemia, or in severe cases, immediate treatment is ordered by our medical officers. Nurses would do the monitoring part of it. So immediate treatment is given intravenously, and we use calcium gluconate in a lot of hospitals. And this is to rapidly raise blood calcium, often followed by a continuous infusion until blood results begin to show an improvement in calcium. But in the case where we don't have lab backups to show calcium changes, we continue to give until a proper assessment is done by a medical officer and the order is given to stop otherwise. It's also critical to correct any coexisting low magnesium, like what Kate was saying, as this can prevent calcium levels from rising too high. In chronic cases, it is managed with oral supplements, and in our setting, we change after giving IV and stabilizing the calcium levels, then our physician changes normally to caltrate, and the patient also caltrate until further review and decisions by our physician. And in cases where treatment must is addressing the underlying issues. For example, in hypothyroidism and all that, definitive management also can be made if it means surgery or otherwise. Next, please.
I went the wrong way. Sorry, Dulcie.
Now, moving on to the other spectrum of calcium. So what happens when calcium rises too high and it goes above the normal range? Hypercalcemia is defined as the serum calcium level greater than 2.1 to 2.6 millimoles. So usually the symptoms that would show would be urinary issues, musculoskeletal pain, gastrointestinal distresses, and psychiatric symptoms. And in cardiac effects, that's what we're going to see on the ECG. So as you can see on the screen again, in life in the first lane, there are categories that is been given for hypercalcemia. So in mild hypercalcemia, the ranges would be 2.7 to 2.9. Moderate hypercalcemia would be from 3 to 3.4, and any level that is greater than 3.4 is considered severe hypercalcemia. Clinical histories that may suggest hypercalcemia would be more of malignancies and hypothyroidism. Next slide. In a patient who has hypercalcemia, the signs or the effects that we're going to see on the ECG would involve a shortened QT interval, and in severe cases, we will see what we call an Osborne wave. So again, we said our QT interval begins at the beginning of the QRS complex to the end of the T wave, and opposite of hypocalcemia, where it is prolonged, we see a shortening. So there is so much of calcium outside the cells. So sometimes the heart starts an early relaxation, and so that's why this interval here becomes shortened. The Osborne wave is also a deflection in the ECG, especially at the J segment or J junction, and this is usually because of the early relaxation of the heart that causes this reflection. So some of the ECGs would show the Osborne wave, but much of the time in our setting, the one that we are familiar with and we recognize always is the shortened QT interval. Next, please. Again, in acute and severe treatment for severe hypercalcemia, we use IV. We primarily use IV hydration with normal saline to dilute the calcium to encourage increase in renal excretion. And then this is followed by medications like loop diuretics, and the common loop diuretic that we use in our setting would be furosemide, and this is to enhance calcium excretion, and calcitonin for a rapid short-term effect. In chronic underlying cases, long-term management focuses on treating the root cause, and again, primary hypothyroidism or malignancy would be treated accordingly, and most of the time, not most of the time, but management and all that would be done by our doctors. Next. Okay, so going back again, if I may, to your slide, Kate, on hypokalemia. So in our setting, the three main ECG disturbances that we diagnosed, I wouldn't be too familiar on the magnesium, and this session here has helped me a lot to understand a lot more on electrolyte imbalances on the ECG. So moving forward, I may be able to maybe see some things that I've never seen before. Yeah, but the most common disturbances that we diagnose would be hypokalemia, hyperkalemia, and hypocalcemia. And again, our doctors would do the management part of it, but the important thing for us nurses who work in the ICU is that based on the clinical history of the patient that comes in, we are already anticipating what kind of disturbances. So if it's severe vomiting, diarrhea, and we are expecting shifts of transcellular shift of potassium, then we are anticipating maybe hypokalemia. Then we are looking for a flattened T wave or an inverted T wave. And if we are beginning to detect that, we would quickly notify our medical officers to do a 12-lead ECG and to commence treatment as soon as possible if lab backups are not available. So while waiting for blood results to come back again, our doctors would always initiate treatments. So as hyperkalemia. So in with potassium, we have oral Spankate that we use, our doctors order to use. In very mild cases with just vomiting and diarrhea coming in, dehydration, electrolyte imbalances, we would hydrate our patients and give oral rehydration solutions to beef up the electrolytes. But then when it goes into moderate and severe, then we need to use IV potassium chloride. We would start at a safe range or inform our doctors to make the orders before we start infusions. And we would always keep the patient on the cardiac monitor and monitor T waves. If we suspect that there is a change in the T waves, we would quickly notify our doctors as well, based on, not based on, but rather in addition to the cardiac monitoring part of it, we would also look at clinical signs like what you said, Kate, the muscle powers, confusion, and that sort of thing, to just to give us a picture of where our patient is in terms of electrolyte imbalances, and we would always communicate that with our doctors. So that is how we would manage our patients. In hyperkalemia, yes, we have calcium gluconate that we would also give to protect or stabilize the cardiac membrane, followed by giving salbutamol nebulizers. We usually give 30 minutes to hourly. If there are very tall peak waves and arrhythmias, we would go 30 minutely and then decrease to hourly, and we keep the patient on the cardiac monitor again, observe very closely. If we are lucky enough to have constant lab backups, it would also help guide our doctor's management of hyperkalemia. So we give that, as well as in terms of dialysis, we don't do hemodialysis, but we do peritoneal dialysis. And we've had a couple of cases where maybe 2 out of 10 patients made it through with peritoneal dialysis. Otherwise, much of our peritoneal or PDs were not successful because we had gone overboard and they were not salvageable. Magnesium disturbances and all that, I wouldn't really comment on that, but we have low magnesium patients, mostly our maternal patients coming with PET or hypothermic toxemia, and they're managed in the maternity unit. So they would give a loading dose of 14 grams, that's 10 grams IMI and 4 grams IV infusion in normal saline over an hour, and then they would continue on maintenance doses. And that's the management that they use for PET mothers. But unless they are very, very critically ill until they come into the ICU, but it's not so common, or maybe because of a knowledge deficit that we are unable to pick up on the ECG. Thanks to you, Kate, for sharing this. Now we are able to rather have some insights into diagnosing such imbalances. I think I've come to the end of my talk, and I'll hand it back to Kate.
Thank you, Dulcie. That was great, and it was a perfect summary, and really helped to contextualize, I guess, what we've learned to your settings as well, which was really great. Thank you so much. I'll put it over to you guys. Do you have any questions for Dulcie, myself, or Beth? You can pop it in the chat or unmute if you like. All right. If there's no questions, we'll just quickly recap what we've gone through. So we went through and had a little revision of the varying components of the ECG. We looked at high and low potassium, magnesium, and calcium. We defined these, explored symptoms that are associated with the conditions and what the treatments are for those. And that is the end of our session. So thank you all for coming. Really appreciate your time, and it's been really lovely to be a part of.
Great. Thanks, Kate, and thanks, Dulcie. That was, I hope you all found that really informative. I certainly did, coming from a place, I'm at intensive care, where we are very fortunate to have ready access to lab and blood gases. So it's easy for us to go and run some bloods and find out if our electrolytes are imbalanced. And the effect that this has is that we are not very good at reading ECGs for that reason. And I certainly have learned a lot from Kate and Dulcie during that talk, especially about, I've never heard of the Osborne wave before. So that's something that I will certainly be keeping a lookout for. All right, so I'm going to just stop recording.